Hi. So you've heard about several initiatives that are happening in this region, and part of the reason for having the afternoon be about that, we heard from policy people and state and even federal people in the morning, and now we're hearing about what's happening locally. And I would just like to comment that the Tree Foundation is now involved in the Healthy Sacramento Coalition, and my hat's off to Sierra Health Foundation for coordinating 82 different organizations of all varying shapes and sizes. As he said, it's not easy to get all these different social and community organizations going in the same direction. So they're doing a wonderful job of that. So thank you. My talk is going to be a little bit different. It's not about our initiative per se. You've heard about our green print, which is our initiative. This is about data. We're back to data. I guess I get to finish the day with data. We've mentioned Desiree Backman, who was our deputy director a couple years ago. She's now chief prevention officer with UC Davis Health Services and the California Department of Healthcare Services. Desiree, when she was here, this is the story. She knew that we were doing a project with the Air Quality District where we had canopy data. And Desiree said, what would happen if we took that canopy data and we matched it up with that data down there that UCLA has? And we, being tree people, said, what data? And it was the California Health Interview Survey, which we didn't realize at the time is one of the gold standards for health information in the nation. And we soon came to learn that that was a big deal. But, so what you see here is canopy data, just a little snippet. Before I get going into the green prescription, I just want to recognize one other thing, and that is that the Tree Foundation, Desiree certainly put us into high gear, maybe turbo mode would be a better way to put it, but the Tree Foundation had been doing health projects for a long time, thanks to Ray's vision, and I will also echo that Ray has never thought of us as a tree planting organization. We are always way beyond that, and that's why we have the reputation across the United States, because of his vision. But we've been involved with skin cancer, Urban Heat Island, the Air Quality District, fruit. We haven't even talked fruit here today. The trees do that. Before I go any further, I would like to note that first one, skin cancer with CDPH in the 1990s, we actually have Don Lyman here. Could you stand up, Don? Don was the head of he was the chief, you were the physician for 30 years at CDPH. Let me put it that way. I get that title confused. But in the way that, and I said, how do we make these connections with people in the health industry? And Ray said, well, I met Don at church, and we talked about it. So you never know where these connections are going to happen, and take advantage of them. So the green prescription, the idea is that we were going to take the canopy and look at the data from CHIS, the California Health Interview Survey, and see if we could see any patterns, any way of saying that there was a correlation or an association. And we've talked about different vocabularies here. And this has been a real exercise in learning vocabularies for the Tree Foundation. What I learned very quickly was that you cannot use the word causality, you can only say correlation, that we will perhaps observe these certain health outcomes in the presence of trees, but I cannot say that trees caused this effect. And the reason is because we are using cross-sectional data. Cross-sectional data means it's data at a point in time, or maybe a couple points in time. It is not a longitudinal data set which takes place over 20 years and they come back every year. So we have to be very careful about that. We would love to say it caused it, but... and so how do you start one of these? Well, you get a lot of experts who are really smart, especially if you're getting into the health world. And of course, we started with Desiree Backman. Right around the time when we got the grant to do this from the California Department of Fire and Forestry Protection, Forestry and Fire Protection, and the USDA Forest Service, Desiree left us to go back to the healthcare world. So she became our chair. And then you can see other people up here, Terry Duarte and Glenna Trichet, who's in the room, Mary Northridge. So we were very happy to have these counselors. I would also like to mention that we have other advisors who are on our Spreading the Canopy grant, which Shannon talked about, such as Sandra Shuri, Bob Waste, Janine Barra, who's a physician, Ami Barra's wife. So we have a lot of experts helping us. This is a big part of why we've been successful with this. So let me talk about the study and the methodology. This is LiDAR. I don't know about you, but I love LiDAR. I think it's a wonderful visual toy in a sense, but it provides incredible data because the LiDAR will provide the height of the tree canopy and will allow us to check out the volume. The first canopy data that we had done was simply done with aerial imagery, and that's a snapshot. And when you're trying to get what's the tree canopy at that point, you run into problems with shadows from buildings, etc. LiDAR, which is, LiDAR is the word light and radar pushed together. There is some people who say it's an acronym. I've heard both things. I checked it out on Wiki. So I'm not sure. But it's really light pulses from an airplane, and then it comes back and it gives you the three-dimensional location in space. And you can develop these pictures, and they just use colors to show the different heights. So the blue is 5 meters, the red is 35 meters, or 100 feet. So we actually ended up using new data because the data that we had was not high resolution enough. So we used this new data from DWR, the Department of Water Resources, and combined with the aerial imagery from NAPE, the agricultural. So that was high res. And this just gives you a glimpse of what they ended up giving us. But the other data that we used was CHIS. And this is considered high resolution data as well because the survey's done every 2 years, or actually continuously now, 50,000 households. They actually get the data geocoded to the house residents. So instead of talking at the zip code level, which is what a lot of health studies do, we're talking at the XY coordinate of where somebody lives. And we ended up contracting with Urban Design for Health because they had the keys to the kingdom to get in to do some of this work with the California Health Interview Survey. Not just anybody can walk in there. They don't want them to walk out with that data. The sample size, by the way, of what we ended up with for the Sacramento region was approximately 5,000 adults. I've got the real number, but that's close. 600 teens and 1,200 children. We did it for all 3 age groups. Because we had their XY coordinate, we were able to do this based on buffers. You know, we had a big debate at this. Are we going to do this at the census block? Are we going to do this at the zip code level, like a lot of other information that comes out of CDPH and the mortality information? But because we had XY coordinates, we decided to do it at specific buffers. And in doing this, we decided actually to do it at specific buffers for specific outcomes. So when we were talking asthma, we used a 100-meter buffer. When we were talking physical activity, we used a larger buffer. At one point, we thought about using a 1-kilometer buffer, but in talking to Jeff Donovan early on, he said that's just too big, and it's not going to give you as much information as you want, and it was going to take a lot of processing. These are hypotheses this was an exploratory study. We were going to try and see, okay, we've heard about all these studies. You know, Jeff Donovan's done this study, Bill Sullivan's done this study. What does it mean locally if you look at our canopy and our health outcomes? And we wanted to look at these particular areas. So you see them all there. You know, asthma. Health agencies were saying to us, boy, if we could say that there's some connection with trees and asthma, we would love it because we haven't got a good solution for that. Overweight, obesity, chronic disease. We know that's one of the biggest issues. We had heard, the literature said that there were connections with social cohesion, mental health, some of these others. What would it say in Sacramento? Well, the ones in red are the ones where we had a statistically significant correlation. And as always, things don't always work out exactly as you expected. We thought that there would be, for example, asthma. We were very happy to see that, but we have also been cautioned, don't get too excited about asthma. And as you heard earlier, Linda Rudolph said that you can't say that about asthma, but we'll talk about that more in just a second. Overweight and obesity, that was adult child. General health, adult teen child. All of these showed positive correlations. That meant in the presence of trees, more tree canopy meant better general health. For the adults, more social cohesion. And then vigorous physical activity. We were hoping to show physical activity that was moderate, that was increased, and transportation walking was increased. It only came up with vigorous, which to us is a little bit of a stumper. We also believe part of the problem there is that when you're dealing with CHIS, it's self-reported data. Somebody gets a questionnaire. They get interviewed over the phone. And so while you can say with fairly good certainty that when you ask them, have you ever been diagnosed as having asthma or high blood pressure or diabetes, that you'll get a good answer. If you say to them, how much did you exercise last week? they might not give you, an exact answer. I kind of figured that the vigorous guys are the ones that track it in their journal every day, and so that's why we got something there. But to really do that well, we have to put an accelerometer on them and follow people around. We were a little surprised that mental health was not on this list. But so there's always things that you want to hear and things that you wished you'd heard. Asthma. As far as asthma goes, we believe that the discussion about asthma is nuanced. The nuance is that we found no correlation with asthma at the beginning when we just did a simple 2-variable analysis. But when we put in high-traffic roadways as another variable, that's when asthma popped up. And as everybody cautions me, well, we have to be more careful about, which trees are you talking about? Because trees are allergens. That's true. But the other thing is that the trees that clean out particulate matter are the needle-leaf evergreen trees. And those are the trees that, what I've been told by physicians and others, have less pollen. So we're back to the right tree in the right place issue. So the next page is where it gets kind of exciting. In looking at the results when we got the technical report, and by the way, we just got the technical report in the last month or two, and we've been reviewing it with our expert advisory committee, and we are going to be talking about what journal articles we're going to write tomorrow. We're going to start more heavily on that now that we have the technical report. So this is all early results, and we are still sifting through this. But in doing this, we asked Jared Ulmer with Urban Design for Health, what does that mean at different canopies? And he called it predictive modeling, and I called him up to make sure that I didn't get too excited about these results, because I got excited about these results. But what it says is that I can't say that if you grow your canopy to 33% that you will decrease obesity by 20%. What I'm allowed to say is in 2 identical populations, one having a 23% canopy and one having 33% canopy, you will see, we expect to find 20% reduction or less obesity, 20% less type 2 diabetes, 10% less obesity over weight, a different category, and increased physical activity. Right now, the average in Sacramento for the urbanized areas, not just one city, but for the urbanized areas, is 23% canopy at this time. And I thought that this was just stunning because Ray has been saying for years that our goal should be 35% canopy for the Sacramento region. You may have seen that Boston or wherever it was back east had 88% tree canopy. It was Washington, D.C. in a previous slide. Don't think that we're going to get there because that's the East Coast where they carved the cities out of forest and we built ours out of grassland and savanna, so it's a bit different. Just to take this to the next one, the teens. Again, this was a smaller sample size, 15% less in neighborhoods with higher tree canopy. The next one, ADHD was one of the results that we found. And so according to the analysis, with higher canopy, we would expect to find a significant reduction in ADHD and even a reduction in child asthma. Now, the real question is, how do we use this data? Data is nice, but how do we use it? How do we impact policy? How does it lead to more targeted research? When we started this, we kept saying, okay, this is maybe the first step because it's exploratory and we're looking at all these different things. A lot of times when you do these journal, or what I've been told happens when you do these peer-reviewed refereed journal articles, is they take a very small, it's kind of like a PhD. You take a very targeted subject and you go really after it. We were doing a broad base. So now, what do we need to go after more focused? And one of the things that we think would be superb would be to go after the physical activity in greater depth, to go after the asthma in greater depth, and as well as the ADHD. But the other thing would be to somehow layer canopy data over longitudinal data, and that's why we get all excited when we hear what Jeff is doing, where he's taking a longitudinal study and overlaying canopy. So we talked about that last year with Sam Surratt, who came from Loma Linda. They have a longitudinal study with Seventh-day Adventists, that's it. And the other thing that we do with it is we talk to our partners, like Robert Phillips, and we say, okay, you have 15 zip codes. What happens when we look at the canopy and the 15 zip codes which have the the worst health outcomes. And in some cases, there is a high canopy in those neighborhoods, but in many cases, there's not. It's a little bit hard to see here, but we've got it by zip code. And that is that. Thank you very much. I'm going to put in one more plug before I turn it over to Steve, and that is on your tables, you have groves of trees. I don't know if you noticed. These were, we wanted them to be beautiful, and we wanted you to pay attention to them and take them home, but they have health facts on them. We didn't want to load you down with an annotated bibliography, but this is something that you could put on your desk, and you can remind yourself that some of this research has already been done, and when you're talking to people, you can use these health facts. Did you know that when you look out your window at trees, you heal faster? What does that mean for when you walk outside in trees? Think about what that means for healing even faster. So we have a bunch of these. They're at the back table. You can take them home. You can share them. You can squash them flat if you want to take the one on your table and put it in your briefcase. It's for you to use. Thank you.